Thanks for the message, Katrina. Just a note to everyone else who's on the line, you don't need to enter the synchronization code. If you can hear okay, that's perfect. Sort of just an extra feature.
I'm just testing again, making sure I'm muted and you can't hear me.
Oh, I can hear you.
It says I'm audio only.
You can try pressing *1 to mute.
Okay,
That's an
I'll
option
try that.
too. Okay. Okay. Well, I think we can get started with the webinar now. So I just want to say a warm welcome to everyone. This webinar is aimed at new registrants, but it's open to any midwife who wants to learn a little bit more about BORN. My name is Heather Olszewski. Don't ever worry about saying my last name. I am one of 2 midwifery coordinators here at BORN. I am responsible for clinical data, and my colleague Vivian Holmberg is responsible for invoicing. So just a couple of little housekeeping items before we get started. If you could all please put your phones on mute. If you need to exit the conference, please just hang up instead of putting your phone on hold. Sometimes people's holds play elevator music or they do that beep, 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 and we all have to listen to that. So if you need to exit, just hang up and dial back in. That's perfectly fine. If you do not have a mute button on your phone, you can press *1 to mute, and then it's again *1 to unmute.
Can you hear me?
I can hear you, yes.
Okay, let me try it.
Sure. Yeah. Yep, that went quiet. I just wanted to direct everyone's attention to the little box down in the bottom left-hand corner. It's a little message box. If for any reason, if you're having a hard time following the slides, I've uploaded a PDF version of the slides right there. You can click on it and then download them. Then there's also just in the navigation panel on the left-hand side at the top, if you wanted to make the slides go full screen from the webinar, there's a little box. It's a square, and it's got another little square inside with a bit of an arrow going to the upper right-hand corner. That makes, if you click that, that makes your slides go full screen, and then it's a little easier to see. So there's also a little slight delay in the webinar, as there is in all webinars. I will do my best to give the slides a chance to keep up with my voice, and so hopefully that works out really well. I'm sorry if I struggle with that. The goal of this webinar is to give you a little more understanding about BORN, how it started, and what the impacts are. We will also discuss data entry best practices, give an example of an uncommon scenario, and talk about clinical reporting. There will also be an opportunity at the end of the webinar for a question and answer period, and I really look forward to hearing your questions at that time, or throughout, as need be. So, BORN Ontario. This is BORN's vision, the best possible beginnings for lifelong health. Everything that we do at BORN is centered around this goal. I'd like to start with a brief overview and history of how BORN came to be. So we're going to back up a little bit, and we're going to begin with a quick history of midwifery data collection in Ontario. In 1994, as I'm sure you all know, midwifery was legislated in Ontario. In 1998, with the first wave of new Ontario MEP graduates, data submission about clients was to the AOM, and it was voluntary. Voluntary data submission has limitations. In 2003, the Ontario Midwifery Program instituted mandatory data collection, and it was a manual form that had to be filled out by hand and mailed in. In 2006, the Ontario Maternal Newborn Health Form became electronic. Until 2009, there were 5 separate data collection systems happening in Ontario for maternal newborn health. They were the NIDA database, prenatal screening, newborn screening, the midwifery data collection, and the Fetal Alert Network, which was for congenital anomalies. Born was founded in this year and combined all 5 of these data sets. This formed the basis of data collection for the Born Information System. In 2012, Born officially launched. It was an online, completely secure way to submit data from all maternal and newborn healthcare providers in the province. So, Registries and Privacy. In 2009, in November, Born was granted registry status under the Personal Health Information Privacy Act, or PHIPA. This allowed Born the authority to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving the provision of health care. The best example for how Born accomplishes this is the Biz provides the ability for real-time notification of missed newborn screens. Newborn Screening Ontario notifies clients through their healthcare provider to ensure that everyone who wants a screen for their baby can get one. Rigorous privacy policies have been reviewed and approved by Ontario's Information and Privacy Commissioner. This is showing an overview of the data that goes into the Biz. We, starting in 2013, began collecting data from all IVF clinics. In addition, we take on all prenatal screening results, antenatal, intrapartum, and postpartum data from hospitals and midwifery practice groups, newborn screening results and follow-up, and NICU data as well. Unlike the databases that came before Born, Born actually links mothers and babies together. So researchers can examine data around babies who had NICU stays and also get information related to their gestations and even their conceptions. This is another way to view the continuum of Born information. On the top bar, we have data from the mother, everything from fertility treatments, if she had them, to her antenatal information, etc. Everything that you see in blue is still in the pilot phase. So at the end here, this is our gestational diabetes follow-up. On the bottom bar, we have data for the child from birth to the 18-month well baby visit and plans to collect up to 5-year visits. And we are rolling out a project to collect data from autism treatment centers as well. From fertility to 18-month well baby visits, Born links the mother and the baby to inform how maternal health conditions, as well as labor and birth interventions, can impact infant outcomes. This slide shows a sampling of some of the data elements collected by Born. We collect identifiers, health status, health history information, risk factors related to pregnancy, care provided, and then we collect data on the outcomes. This shows the impact visually of the data on both the individual and up through the system. The same information we use to identify a child missed for newborn screening is the same level of data we use to inform providers, organizations, and the population at large. This is population-level data to a level of detail where we can be confident right down to the individual birth. So a note about where to find resources. The place to find resources on Born in general and how to enter data into the Biz is on our website, so www.bornontario.ca. Go to Born Information System, which is here in the gray bar, second one there, and then go to Data Collection Resources, here on the left-hand navigation, and then here we've got a section on hospitals as well as midwifery, so a whole section for midwifery. These Born information bits are short little PDFs that teach one specific skill, such as how to create a subsequent pregnancy in the Biz. Of particular use is the Downtime Form section. This contains PDF files of each encounter with all data elements clearly laid out. This is in case of Biz downtimes. You can write out the information you need about a client in a Biz-specific format and then add it to the Biz at a later date. How midwives contribute to the Biz. Clinical data on every course of care, good quality data, is used to confirm the quality of care provided by midwives to clients all over the province. The data contributed by midwives adds to the continuum of data from fertility to child, capturing the true client experience. In addition, there are opportunities to use the data to further midwifery-specific research. So moving on to data entry, all the ways data gets into the BIZ, Born Information System. So this shows the encounters that are created for a home birth. As you know, a maternal client requires antenatal general, labor, birth mother, and postpartum mother encounters. All the data is entered manually. So this shows our sample fake client, Angela McCourt, who had a home birth for her baby Frank. So data entry for a hospital birth. At some hospitals, midwives have born access under the hospital in addition to their practice. These midwives enter clinical data directly into Born as a hospital user. For manual data entry, nurses and midwives can enter information in real time, which means at the bedside, so at the time of labor and birth, or within 24 hours of discharge. There's also the option for retrospective data entry that's done by health records coders or unit clerks more than 24 hours after discharge, by chart abstraction, or by downtime forms. And then there's also batch upload. So midwives enter information about their client directly into the hospital's electronic medical record. Then a designated person at the hospital uploads the EMR information directly to Born. Midwives then have to go into the BIZ to create their MPG encounters once the hospital data has been uploaded for them. So now we're moving on to data entry best practices. So my expert tip, use the appropriate browser. Currently, the BIZ supports the following browsers: Internet Explorer version 8 or newer. You probably all have version 11. That's the current one. And Firefox. So we have Internet Explorer that's aimed at PC users and Firefox that's aimed at Mac users. So using another browser such as Safari or Chrome, you'll be able to open the BIZ and you'll be able to do some work in it, but it's not going to work perfectly. You will see decreased functionality. So we just just as a snapshot, that's from our reporting page, and it does say recommend using IE 8 or more. Google Chrome is not supported. Biz Messaging. This is the only secure way to send personal health information to coordinators. So personal health information being OHIP numbers, client names, chart IDs. So how you access Biz Messaging is log on to the BIZ, and then you select Messaging from the top of the page navigation. It will bring you to our secure messaging application, and you can send me a message from there, and it can include as much information as you need to send me about the client that you need help with. Which encounter first? So with the exception of the antenatal general encounter, we always do the hospital encounters first. So why does that matter? This concept can feel confusing, so I wanted to elaborate a little on why this is important. Hospital encounters, should contain data related only to the care that happened at the hospital. They are geographic-based encounters. Care provided before admission or after discharge should not be included in the hospital encounter. MPG encounters contain data related to the entire course of care provided by the practice. So they are care-based encounters. They should cover all of the care provided by the practice group regardless of the location. So the first created encounter populates the second encounter, with the exception, of course, of the midwifery tab, because hospital encounters don't have midwifery tabs. So for midwives who enter data for their hospital, create the hospital encounter, enter data for all events that happened at the hospital and the care provided there, open up the MPG encounter, and add any extra care that occurred outside the hospital setting, and also enter the midwifery tab data elements. Make sure you review the data before you submit it. So why do we have two encounters for a hospital birth? It's to satisfy reporting requirements. Organizations cannot report on data from other organizations. A hospital cannot access or report on data from your midwifery practice group. And likewise, your MPG cannot report on data from the hospital. When there are two encounters for a hospital birth, each organization has access to the data around the client who used their services so that they can report on it. So we enter the data once. Hospital data populates the midwifery encounters. The same data goes in two places, but it's entered once. So you don't have to enter it again because of pre-population, but you do have to review it to ensure that it's reflective of the care provided. Somebody is not on mute. If you just wouldn't mind just checking your phones to see that you're on mute, I'd appreciate that. Thanks. So this is data entry for a hospital birth done in the correct order. So here is my sample client, Lady McBirth, who had a hospital birth. And so you can see the antenatal general was created first for the MPG, of course, and then the following encounters are created under the hospital first. So here we have labor birth, down to the hospital, MPG. You guys know what this looks like. So it creates two identical sets of the same data. One that the hospital can use for reporting on their data, and one that the MPG or individual midwife can use to report on their data. The midwifery encounters also have a separate tab for midwifery-specific data elements, such as was the baby born in water, maternal position at the time of birth, etc. Collaborate with your hospital on hospital birth data collection because the data needs to be submitted to BORN within 2 weeks of the birth. Some hospitals require it to be done before the midwife leaves the hospital, and some require it to be done within 2 weeks of the birth, and others have variants of this. The goal is to capture 100% of all births with the best possible data quality. So now I wanted to talk about entering an uncommon scenario. So they do happen, just not commonly. So if you aren't certain how to enter a situation, try the BORN website. And again, you go to BORN Information System in that top gray bar, Data Entry Training, and then select Midwifery. Or you can contact your BORN coordinator. That's me. That's my BORN Glamour shot. By email, by phone, or by Biz Messaging for help. And that's my phone number. Sorry, that's my email address right there. I also have it on the last slide. So just a note, please only use email to contact me with non-PHI messages. So no PHI in email. You can send me a biz message for that, or you can phone me. I'm an extrovert and I work from home, so I love to get phone calls. Phone me anytime. I love to chat. So here's an example of an uncommon scenario. I get a lot of questions about this. How to enter a stillbirth or a termination that happened at greater than or equal to 20 weeks. So BORN collects data on all live and stillbirths in Ontario as defined by the Vital Statistics Act. This means that we enter data on all live stillbirths and terminations that meet any one of the following criteria. The birth occurs at 20 plus 0 or greater weeks gestation. The infant weighed 500 grams or more at birth. The infant showed any signs of life at birth, meaning that it attempted to breathe. That's one example. So what we do is we actually create all encounters for these births, including creating a birth child encounter. On the Outcome tab of the Labor Birth Mother encounter, you select the appropriate option for maternal outcome. So we have stillbirth at greater than or equal to 20 weeks or greater than or equal to 500 grams. Occurring during antepartum, intrapartum, or as a result of termination. If you don't have access to the baby's chart, these can be tricky records to create for infants. Sometimes the mother has delivered at another hospital where her midwife didn't have privileges because she was out of town when she delivered a stillborn or very preterm infant who did not survive. So what to do if you can't easily locate the infant in the biz to link the maternal client? Contact your midwifery coordinator by biz message. Send me as much detail as you can about the maternal client and anything you might have about the infant, especially if you know where they were born, and I will find them and link them to the maternal client for you. So now we're on to clinical reporting. Clinical reports provide a variety of indicators and compare them to provincial data for midwifery clients. So, for example, we show things like VBAC rates, planned place of birth, or actual place of birth, by planned place of birth, episiotomy rates, fetal surveillance, and a whole lot more. To access clinical reports, the local administrator for your practice grants access. So they go into your Biz user profile and they check this little tick box beside midwifery data analysis clinical reports, and then they click save, and that will give you access to clinical reports. For lots of information about about the various reports we have, you can see our newly released midwifery reporting guide. So that was sent out to each practice group by email in November. And of course, we also put it on our website. So you go to the Born website, again, go to Born Information System in this gray bar. Then you go to Reporting Resources, right down here on the left-hand navigation. And you will find it there under midwifery. Under reference documents, I apologize. This document outlines how to access and use every single report in our system available to midwives. It also has a section about how to export to Excel, how to add filters, and how to really manipulate the document to give you the data you need. So when you log into the Biz and you go to the reporting page, if you select the Clinical Reports tab, this is a snapshot of what you'll see. So we'll zoom in a little bit. At the top, we have data download reports. So we have encounter list reports and midwifery client experience reports in this particular bucket of reports. The encounter reports contain every data element in the designated encounter. So the encounter list antenatal general report contains every data element in the antenatal general encounters. The midwifery client experience report lists all maternal or infant records within a specified date range and includes all data elements related to all encounters. The Consultations Report lists all maternal or infant records that have at least one consultation. You export the report to Excel, add filters along the top row, and then filter for whatever data elements you are looking for. This would allow you to, for example, determine how many clients in a set period of time developed gestational diabetes or came into care with mental health conditions, etc. Underneath data download reports, we have maternal newborn reports. So these clinical reports demonstrate various indicators related to demographics, forward sortation area, that's FSA right here, that's your postal code. Utilization of services, that's things like length of stay, OHIP coverage, etc. And we have labor, birth, and newborn outcomes. These reports can be run for an individual midwife, either as coordinating or primary midwife, or for the entire practice. The report also publishes comparator data, all midwifery clients in Ontario for the same time frame. So, how to run a report. First thing, make sure that pop-ups are not disabled. If you click on a report and nothing happens, check your pop-up status. Once you have this exported into a pop-up window, the first thing to enter is the date range that you're looking for. The next step is to filter either by MPG to run it for your whole practice, or by primary midwife to run it for yourself as a primary midwife, or coordinating midwife, so same thing for yourself as coordinating midwife. Then you go to view report and click that. And once the report has generated, it's a lot easier to look at it and play with it a bit if you export it to Excel. So you head over here to our little floppy disk icon that has a little arrow, and you click on it, and you'll get a drop-down list, and you can select Excel from the drop-down list for exporting. Once you export the report to Excel, the first page is pretty much blank. You'll see a whole bunch of tabs along the bottom, and they all contain all of these various different tables. All of these different tables have different indicators around birth that midwives often want to measure. So this is the first tab. So this is a fictional midwifery practice group that I created called the Birth House Midwives, MPG 613. And so I made up data for them. So this is all invented data, but it is compared with real midwifery client in Ontario data. So this displays vaginal and cesarean birth rates for total women who gave birth in that time frame in this practice, further subdivided by primips and by multips. And then we further break it down into a really simple low-risk criteria: singleton pregnancy, vertex baby, term baby, no previous C-section or uterine surgery, further broken down by primips and by multips. And again, compared to all midwifery clients in Ontario. Further down on that same tab, you'll find type of vaginal birth. So we further broke down, again, using this fake practice with made-up data, spontaneous vaginal birth versus assisted vaginal birth, and then assisted vaginal birth is further broken down by vacuum, forceps, or vacuum and forceps for total women who had a vaginal birth, for primips, and for multips, and then for our low-risk criteria, a singleton vertex term, no previous C-section, broken down by primips and by multips. So other interesting data in the report, there's a lot in that report. It's really fun to look at. We have type of birth by planned and actual place of birth. We have perineal trauma and episiotomy by type of birth by number of fetuses, fetal presentation at time of birth by parity and type of birth, and primary indication for planned and elective cesarean sections. So I just wanted to share this. This is really exciting news for Born. So this is an example of data at the population level. So this study was just published in the BMJ about 2 weeks ago. I think it was November 24th, 23rd. It's an analysis done by Born staff on the effect of the maternal newborn dashboard that's present if you log in the hospital. It concluded that the dashboard, which is an audit and feedback tool, was associated with statistically significant reductions in the following interventions. Episiotomy decreased by 1.5%. Inductions for post-date clients at less than 41 weeks decreased by 11.7%. And there was a decrease in repeat C-section for low-risk women prior to 39 weeks of 10.4%. So we were really excited and proud of that. Okay. And so now we're up to our questions and answer phase. So if anyone has any questions, please feel free. And just a reminder, if you muted your phone with *1, you unmute your phone with *1 as well. So if there's no direct questions, then I guess
Heather?
I have a... Yes.
Yeah, Heather, it's Dee Dee. There's one question with respect to emailing the dashboard publication to
to practices, for sure.
Yeah, so Corey, if you want to send Heather an email just to connect with her, she'll be able to get that to you.
Yep, feel free. There's my email address. I'm really sorry about the last name. It's just a whole bunch of consonants. I'm sorry.
And I have a question about what you were talking about with the hospital record versus non-hospital record. I was wondering if you could just point out on that left-hand menu that we're used to seeing what you mean by that.
Sure. Let me tab back. I'm sorry if I'm making anybody dizzy. I'll just tab back to that. Here we go. So here, under labor and birth, first you see, so the first created encounter goes in first. So this has the general, the Ottawa Hospital General Campus. So that's their hospital encounter was created first for labor and birth. And
Heather, sorry, it's Laurel. Could you use your cursor to point out what piece of it you're talking to?
Sorry, can people not see it? Not see my cursor because I'm using it?
No, I can't see your cursor. Sorry.
Oh, okay. So, all right, it's there, but I'm sorry that nobody can see it. If you go down on the left-hand side, under the orange highlighted Lady McBirth, if we could keep on going down under prenatal screening, antenatal care, labor and birth, then we see these two blue tabs. We've got TOH, which is the Ottawa Hospital, so that's the hospital encounter first, and then the midwife created the postpartum, the practice group encounter. And same thing for a postpartum mother. You can see the first created one was the hospital, and the second created was the practice group.
And both of them would look the same in terms of the tabs that we have: admission, history, pregnancy, across the top?
Yes, the only one that looks different is Midwifery tab, of course, because when you log in as a hospital user and you go into your hospital encounter, you won't see the Midwifery tab. That one doesn't display, but the rest of them, yes, they all look the same.
Okay. So if I'm logging in and I just start at the top and work my way down and start on the left and work my way across, is there anything different I need to do, or that should cover? So log in as a hospital user. If you do manual data entry for your hospital, I take it? I don't.
You don't? Okay.
Well, I'm not sure if I do.
Do you have an EMR at your hospital?
No.
It's Vivian. I'll jump in. What hospital is it?
This is the Civic.
The Civic. Okay. So the Civic is one of the hospitals where clerks do the data entry for you retrospectively, so after you've left the hospital. So for you wait for the clerk to have the hospital data entered for you. But I do understand that that's changing, and so nurses might be starting to enter some of the data?
Over the next year or so, yes.
Okay. Yeah, so wait for the hospital to put in their data, and then you go in as a user for your practice group and create your encounters there, and then just review the data and ensure that it's accurate, add any midwifery-specific data elements, and then press submit.
Okay. Any other questions?
I have a question.
Okay.
Along the same line, the antenatal general, you've got the MPG as having put that in, but I usually do it on the hospital tab first while I'm at the hospital. I never put it in advance. Is that
okay. Which hospital are you at?
St. Joseph's Healthcare, Hamilton.
St. Joseph's in Hamilton. So I could be wrong. Vivi, you can jump in, but you don't necessarily need to do a hospital antenatal general encounter.
But it transfers over to the MPG one anyway, so.
Yeah. So you
Sorry, excuse me. There is no requirement to do a hospital antenatal general encounter, but when you go in under your practice group, you will have to do an antenatal general encounter. Every course of care needs that antenatal general record. created, and submitted. But the order doesn't matter, really and truly. What is entered in under the pregnancy and the history tabs in any encounter will be available for you. It'll populate to the antenatal general encounter, but please do review it and make sure that it's accurate before you submit it.
Okay, but if I did it from my MPG first, would it populate over to the hospital site as well?
Absolutely. Yeah, but we recommend strongly that you do the hospital piece first. And
for labor, birth, and postpartum.
Yeah, for labor, birth, and postpartum.
Yeah,
some hospitals do an antenatal encounter. It's not a requirement. It depends on the practices at the individual hospital, and I don't know offhand with respect to St. Joe's whether that is a requirement or not. But the information, once it's in, will populate, and please review it before you submit it.
Okay, but I'm thinking it's okay that I continue what I already do. Like, I'll do it at the birth. I'll do the antenatal and the labor and birth, all of that at the hospital. That's fine.
Yeah.
Okay.
That's it. Great. Get it done, and it's done. Yeah.
Thank you.
No problem. Any other questions? There aren't any. I have one question, just sort of an open-ended question that you can either answer verbally or you can send me emails later on. But I'm curious what resources new registrants would like to see from us to help you enter data better. No? Okay.
I have a comment, but I'm not a new registrant.
Oh, that's fine.
Sometimes I would like to see better timelines on, I get sometimes a little confused when I've transferred someone antenatally. So then, of course, I don't tend to write that there's a complication in labor, even if there was one, because it's not. I haven't consulted for a complication, let's say, because she wasn't in my care anymore, or just timelines about when this postpartum period ends. Is it within 24 hours or before she leaves the hospital? So I can't come up with any examples right now, but every once in a while I get struck with not being totally clear, and I want my information to be accurate, but I have that.
So I think I get what you mean by that. So are you asking how long the period of time is that the postpartum encounter lasts for?
Yeah, that was part of it, yeah.
Yeah, sure. So great question. So the postpartum hospital encounter, because it's a geographic-based encounter, it covers the woman from about 1 hour post-birth until she leaves the hospital. But your midwifery practice group encounter covers her from about 1 hour postpartum until she leaves your care. And so that's why we talk about the hospital encounters being sort of geographic-based, and so that should have all of the data related to anything that happened to her there. So if you did a consult postpartum for something in hospital before she was discharged, then you would put it in that encounter in the hospital one. But if you did a consult, say, for mastitis at 4 weeks postpartum or whatever, then you would have that in your midwifery postpartum encounter. Does that help answer your question?
Yeah.
And I'll answer the question about transfer of care and consultations. So for anyone who is transferred out of midwifery care, if there's a consultation prior to the transfer of care, absolutely, it can be entered on the midwifery tab, the appropriate midwifery tab. So if that's done prenatally, put it on the antenatal general encounter, and then you'll be able to also note that there was a transfer of care and when care was returned to the midwife, if it was in fact done. But if you've transferred a client already and you've entered that antenatal or prenatal transfer of care, then that suffices. If there's other consultations within there, if you're still attending the birth and stuff, you're not the most responsible care provider, you're also then not responsible to enter those consultations until the woman is back in your care. Does that make sense?
Yeah, sure.
Only midwives track information related to consultations with physicians or transfers of care to other care providers. So hospitals don't ask or answer those kinds of questions. So it really relates to your care as a midwife.
Okay, great, thank you.
Hi, this is Claire. I just wanted to add something.
Okay.
So I'm not a new registrant, but I'm an early practitioner, and you're asking for suggestions. Some of the things that I made a lot of mistakes in my first year was like where to put things and where they were applicable, and it seems kind of stupid, honestly. Like I didn't realize like certain things went in certain spots. So a suggestion, maybe, I don't know if people would be interested, but for new registrants, even just having like a step-by-step, like have a case, like an actual chart of somebody, and you would take the time to go through it and click everything and show people where it goes, because like simple mistakes I was making was I wasn't cluing in that, like the birth was literally just the birth, and did I consult at that time? Was the consult before? Was it after? Was there a transfer of care at that time, or was it, those little things? So I think my data may have not gone in properly. I don't know. That's just one suggestion. Another question I had was when we have things like the Ontario Newborn Screen that's done in the community, where would we put that in to the data? Because it's not done in the hospital, so where do I put that in?
They put that in. So you can put in postpartum, not in postpartum mother, you can put that there's a referral to community. Sorry, I'm drawing a blank on which.
Yeah, that's okay. Heather, I'll jump in, Heather. There is a question, was HPHC? I'm sorry, did you say newborn screening?
Yeah, it was that's one example, newborn screen. Like, where do I put that if I did it on, day 2 or day 3 in the community? How do I capture that data in the program, in the Biz or whatever?
So postpartum screening we do capture on the postpartum mom encounter. Newborn screening, though, is no longer a data element that needs to be collected. So the screen will come in. From Newborn Screen Ontario into the Born Information System, and you might see it up towards the top of the child record, which we don't have a picture of right now. But you'll see the Newborn Screen record. As a midwife, you don't have access to it in the Born Information System, but you can see that it is, in fact, there.
So I don't have to worry about so it's just pre-populated, in other words.
It comes in directly from the one newborn screening lab that you send your sample to.
Okay, thanks very much.
Yeah, you'll be able to, it'll just be grayed out, but you'll see it under newborn screening, and of course it's under the baby, so it's not like this one's a bad example that we're looking at right here because this is the mother, but it's under the infant. There's a newborn screening, you'll just see it grayed out, but it'll be there.
So here's the other thought is just that in the hospital tab where it's the newborn screen, it's asking, was there comfort measures like breastfeeding, skin to skin, blah, blah, blah. But that's not captured if it's done in the community with midwives. I don't know if that's important data or not, but that's the piece that I think is missing if we've done anything. But
those questions are still there.
Yeah.
But we can take a look at the visibility of those for sure.
Okay.
Visibility. I'm writing this down. Okay. Any other thoughts or questions?
It's Amy here. I'm not a new registrant, but I have a question.
No, that's totally fine.
My question is regarding consultations that the midwife did not initiate. So, for example, a client goes to see her family doctor at 3 weeks postpartum for an ingrown toenail, and while she's there, the physician auscultates the baby's heart and finds a murmur, and the baby therefore gets investigation for that murmur. the midwife didn't instigate that, but the child then had outpatient investigations and a pediatric consultation.
Yeah,
Do we chart that?
I don't know if you chart it or not. I can't answer that question necessarily, but in the Born Information System, you don't need to put down that as a consultation that doesn't relate to the care that you provided yourself.
So we don't put that in Born?
No, you don't.
Correct.
Need to.
Okay, and I have a second question.
Sure.
It's a two-part question. How come Born is not capturing newborn male circumcision rates? And also, if a client chooses newborn circumcision and the midwife, I don't chart that as a consultation because I'm not the one instigating that consultation. The parents do it. So is that correct?
That's correct. You don't need to. You don't need to enter that consultation into the system. We had discussion in early days about whether male circumcision was in fact something that needed to be collected, and then Born doesn't collect information on absolutely everything that happens with every woman giving birth and every baby born. It was decided at the time that there wasn't a strong enough reason to include that specifically. But if that has changed, feel free to send us or send Heather an email about what your rationale might be about a need to collect that information for the purposes of what the Born does, and we will put it on our list of enhancements and undertake a review process.
Sure.
Does that help?
Sure, thanks.
Great. Anything else? All right. Well, I want to thank you all so much for spending your lunch hour with me. I really appreciate it. Again, give us a phone call or send me an email anytime you have questions. Always happy to chat. Send me a Biz message if you have PHI to share with me. And have a wonderful rest of your day.